Good. So we've got Dr. Karin Leslie speaking next from Ashford and St Peters, consultant obstetrician, and she also leads Surrey Heartland's Maternal Medicine Network. She's going to be talking to us today, and sorry, Karin, we're running a little bit late, so we'll eat into the lunchtime a bit, but we're going to be talking on the assessment and management of anemia in pregnancy. Over to you, Karin.
Judy, can you hear me okay? Because I've not checked my microphone. Yeah.
Yep.
How do I screen share?
Yes.
Yeah. Fine. Hang on. There we are. I'm just going to check. Got my slides.
Yep, I can see your slides, and you're just about to go to slideshow. Yeah, that's perfect.
So hopefully that's right.
Karen.
Yeah. Text me if anything technologically goes wrong.
Yeah, we'll do.
So we're going to cover an overview of anemia in pregnancy, a little bit of an approach to a differential diagnosis, because the vast majority are iron deficiency, but some of what we see isn't. We're going to have quite a focus on iron deficiency anemia because it seems a relatively straightforward and easy thing, but actually there's a lot we can do to improve how we manage it and how we prescribe. And lastly, we'll have a bit of a think about folate and B12 deficiencies, which are common, and actually I think we're seeing more of them. I certainly feel like I am. So anemia in pregnancy is really common. So globally, around 40% of pregnant women, the WHO estimate, are anemic. Correlates really highly with economic status. So women in sub-Saharan Africa have very, very high rates of really quite significant anemia. And globally, iron deficiency is the commonest cause, so around about 40% of cases, and I'd say that that's also what maps to the UK as well. We do also see other nutrient deficiencies, particularly B12 and folate, in more tropical climes, but perhaps with women who travel, and I've certainly seen malaria in pregnancy in this country and women who've gone back to visit family and come back, but malaria and parasitic infections will cause anemia. We have inherited red cell disorders, so we should be seeing that on their booking bloods and their hemoglobin electrophoresis, but women with sickle cell or thalassemia or traits. And lastly, chronic disease, so either renal, autoimmune inflammatory, can also cause anemia. And you can see a little pictorial representation from one of the TOG articles, sort of looking at iron deficiency anemia is not a diagnosis in itself. So absolutely pregnancy and the demands of pregnancy is the commonest cause, but there may be an additional underlying reason that we also need to think about and perhaps treat and address. So classically, we very much think about anemia and putting it into subcategories of microcytic, so very small red blood cells, normocytic, normal size red blood cells, or macrocytic, megaloblastic, larger red blood cells. But can be actually quite tricky in pregnancy. So you can have more than one type of nutrient deficiency. So if you have iron deficiency, that may actually cause symptoms or problems before the cells have time to get small. If you have a combined nutrient deficiency, it's not uncommon to be folate and iron and B12 deficient, you may not see the kind of macrocytic picture that we're expecting to see. So it helps, and it's definitely useful to look at, but I don't think it's the be all and end all. We have to sort of think, you know, I suppose in a little bit more of a detailed way. And if people appear to be iron deficient but aren't responding in the way you'd expect them to do, that's a definite prompt after 2 weeks to kind of think, well, what else is going on and what do I need to check for? I'm not an advocate for all initial blood tests showing a slightly low hemoglobin of doing, you know, screening for everything. But I think we do need to kind of monitor a response to treatment and follow women up. And that's not always easy in our busy clinics and busy maternity services. Ferritin's probably the most reliable indicator. So there's lots of quite complicated iron studies, which I always really struggle to remember and work out what they're meant to show. But actually ferritin there's decent data showing that actually it is pretty good in terms of reflecting total body iron stores. And the UK cutoff we use of a cutoff of less than 30, which is in the British Haematology Society guidelines, is pretty good, 92% sensitive and 98% specific. But actually, even when you're going to higher levels than that, you can still be low on overall iron stores, and pregnancy consumes a huge amount of iron. So full blood count and ferritin, I think, are probably the mainstay first line for most women you'll see. Think about other causes. So, you know, gestation, what other symptoms do they have? Is this a hemolytic anemia and preeclampsia? That's much less common, but we do need to think about it. What are the other parts of your full blood count showing and telling you? So what are the platelets? What are the white cell count? We definitely have women with poor diet, inflammatory bowel disease, increasing numbers of women with malabsorptions, bariatric surgery, need to consider eating disorders, not just anorexia, but restrictive eating and sort of binge and purge cycle eating can all have an impact on women's nutrient status. And then lastly, we've already talked a little bit about infection, but HIV, malaria, sickle cell, and other conditions, we know autoimmune can also factor in. And you might want to go on and think about doing a blood film, an LDH level if you think there's hemolysis. That often goes up with B12 deficiency because the red cells aren't forming properly and they fragment in their immature early stages. Iron studies, total iron binding capacity, and really, really rarely, but occasionally where we're really stuck and we can't figure this out, women very unusually in pregnancy might have a bone marrow test, usually postnatally. So we're going to spend a little bit of time focusing in on iron deficiency anemia because that is probably the most common. So in the UK, the NHS Blood and Transplant Authority estimate that 25% of pregnant women are iron deficient. And that really is because of an increased demand in pregnancy. But women very often come into pregnancy if you've had a baby not that long ago, if you've had a baby then breastfed and then gone straight into your next pregnancy, and lots of those other reasons we talked about already. There may be a reduced absorption, so women that are on prolonged proton pump inhibitors that have changes in medicines that can impact on their absorption can all factor into why women come into pregnancy not necessarily anemic but deplete in their iron stores, and then layer in the increased demand of pregnancy, the expansion of blood volume, and you can look okay at booking and then become really quite anemic by the time you're getting to 28 weeks and coming up to birth. So definitions, British Haematology Society and RCOG, they use trimester specific cutoffs reflecting the sort of natural hemodilution we see. So 110 in the first trimester, 105 second and third, and then 100 postpartum. And the WHO criteria are reasonably similar, but they break things up into mild, moderate, and severe. And that's just an infographic which shows pictorially those cutoffs. So symptoms, I mean, we're all aware of things like fatigue, weakness, irritability. You quite often feel that way ourselves after a busy time at work. But there are some quite specific iron deficiency symptoms which are described, so such as pica. You can get that as part of the normal kind of pregnancy phenomenon, but it's more exaggerated in iron deficiency. And they're saying ice and soil. I've definitely had women that almost want to suck on coins or metal as well. And women will describe lots and lots of different symptoms, but there is an absolute evidence-based link between cognition, work performance, and work capacity and anemia, but also actually depleted iron stores. So women that aren't anemic but have very low ferritin levels have an improvement in quality of life scores and improvement in some of these other quality of life measures compared to women that don't have treatment. Signs, really, really unusual nowadays for us to see this classic sort of spoon-shaped nail, the koilonychia, but that's classically described. Other nail signs might be little white lines, or you can sort of see them here, and and nail bed changes, tongue changes, signs you might see, again, a loss of the kind of papillary structure, and glossitis or irritation, and this angular stomatitis, which I've seen. In more severe forms, and again, it would be really unusual nowadays for us to significantly be seeing this, but you might have evidence of heart failure. But in its milder forms, peripheral edema, tachycardia, and a functional flow murmur. Now, the difficult thing is you can get those in normal pregnancy. So it can be really difficult to work out actually what is due. And iron deficiency is so common, there's a huge overlap with those symptoms of normal pregnancy. A little bit of the science, because actually, like, if we understand sort of iron metabolism, then it begins to help us understand like why it's so important. Why do we get these really widespread symptoms when the iron stores are low, and also just quite how cleverly our bodies control iron metabolism. So iron's a really critical trace element. So we all know it's important for hemoglobin and carrying oxygen, but it's also a critical part of lots of different enzymes which catalyze essential reactions. And on average, we contain about 3 to 4 grams of iron. Most of that at any given time is actually stored or contained within our red blood cells in the hemoglobin in the heme. But actually iron is also stored bound to ferritin in your peripheral organs, but mainly in the liver, with a little bit in the spleen and the bone marrow. And only a really small part of our total iron circulates within our plasma. And that has a really high turnover. So it's constantly kind of turning over, and the amount of iron that's just circulating around our bloodstream is turning over all the time. And most of it's bound to transferrin. And your plasma will also contain ferritin, which we can then do a blood sample and measure. Most of the turnover within your plasma is from the breakdown of red blood cells, and some of it coming in from new dietary contributions. Hepcidin is a really, really important master iron regulator, and it's important that we know about this because this influences some of our newer thinking about iron dosing and how we're prescribing iron. So when you have higher levels of iron, you have increased liver hepcidin, you then have a degradation of the transport pump. So there's an import and an export pump in the small bowel cells, and essentially it's your duodenum, so it's your duodenal enterocyte, so your site of absorption is high up in the small bowel and quite specific, and that's what will control the absorption. In pregnancy, you already have a down regulation of that. So the body is cleverly adapting to sort of optimize iron absorption. So it's optimizing that import and export pump to be able to extract as much dietary iron as possible. Our demand goes up hugely. So outside pregnancy, your demand is about 1 to 2 milligrams. In pregnancy, it goes up to 6 milligrams, and that rises throughout pregnancy. So your recommended daily allowance in the latter half of pregnancy is 27 milligrams, twice that of a non-pregnant woman. And the difference between actually what you need, the 1 to 2 milligrams versus, and then the 6 milligrams versus the 27, reflects the fact that only a small amount of that is actually absorbed across the bowel. And if we think about where that extra iron goes, it goes into fetal growth, it goes into the placenta, it goes into increasing your red cell mass, and then sort of preparing and accommodating for normal blood loss with a birth. So your clinical effects of iron deficiency anemia, we've already kind of touched on the symptoms, so fatigue, but we also get thyroid dysfunction. The evidence tells us that women have higher rates of PPH, so they're less able to respond to blood loss, but they're also actually at increased risk of having that. And we're not sure why, but that may be because actually if you're not able to make hemoglobin, you're probably not able to make myoglobin of a good quality, and you may have impaired cellular oxygenation, which then impacts on how able the uterus is to contract well after delivery. And we know women that are iron deficient anemic are more likely to end up with significant morbidity, needing transfusion and going to intensive care. There's a little bit of a link between infection and puerperal sepsis and wound healing, reasonably evidence-based link between iron deficiency and postnatal depression, and less success in breastfeeding. There's also really important impacts on the pregnancy itself and the fetus. So there's evidence showing a link between low iron levels and iron deficiency in preterm birth and stillbirth and low birth weight. And we know that if the mum is iron deficient, then the baby is born with low iron stores, much more likely to be anemic in childhood. And there is some longer term evidence that there's an impact on neurodevelopmental outcomes in childhood. So it's an important thing to get right. And this is a common problem that affects a quarter of our women. So prevention, obviously dietary advice, but you're going to struggle if you're already low in your iron stores to get enough just from your diet. And there's lots of helpful patient information about dietary sources that help, from oily fish, dark green vegetables, but you know, the sort of traditional myth that it's just in red meat and spinach is not true. Current national guidance of the British Haematology Society advises that we identify high-risk groups at delivery, so women that are at a higher risk of developing iron deficiency anemia. And actually, you can consider routine ferritin testing if your local population is at high risk. So it's not part of routine booking bloods or screening. We locally do a routine ferritin level at 28 weeks, and we just kind of introduced that slightly under the radar, and that was because our local population had very, very high levels of anemia by the time of birth, and moving that checking downstream and not waiting for women to actually become anemic before you support them with iron very definitely makes a difference. So who is at increased risk? Well, we've already talked about some of the factors, you know, sort of coming into pregnancy, but if you have a multiple pregnancy, your iron demands are going to be higher. If you've had, you know, extra numbers of babies, again, you will have used up more of your iron stores supporting those pregnancies and then feeding. Short birth intervals, teenage pregnancies, if you've needed a previous transfusion or you've had a hemorrhage, vegan and vegetarian diets, malabsorption, recent history of significant bleeding, and then we're on to women that might not be actually at increased risk of iron deficiency, but actually they are at more risk if there's bleeding, and you need to optimize their blood counts as much as possible. So women who would refuse blood, women who are at very high risk of bleeding, and women where it's going to be more difficult to transfuse them, so atypical antibodies. That's just our local flow chart, and I'm sure, well, I'd hope this is such a common problem that pretty much all the units we're all working in have a kind of sensible, structured approach to actively sort of managing iron deficiency, not only in treating once it's identified, but actually in being proactive and trying to prevent it if at all possible. And national guidelines advise that you can adopt a number of approaches, so you can either robustly check women, so you can do a ferritin and then treat, or you can almost prophylactically give women who you feel are at higher risk iron, and then recheck, and if they do develop anemia, then go and check ferritins. I think it's difficult asking women to take medication or prophylactic treatment without them really understanding what's going on, and certainly in my experience, I think it's if you take the time to explain things like iron stores and their ferritin levels and correlate it to how they're feeling and what their individual kind of history is, then they are much more likely to be on board with taking iron, understanding why, and being able to manage it and cope with some of the GI side effects, which we know are an impact. If we're just sort of asking women to take it because we've decided they're at higher risk, I think you're less likely to get good adherence, but that's just my view on it. So prescribing iron. Oral iron is an effective, cheap and safe way to replace iron, and the British Haematology Society advised 40 to 80 milligrams. And if I was doing this talk live, I'd be asking for a show of hands about anybody who prescribes or sees other people prescribing 2, even 3 times daily. If there's one message to take away from this talk, is please don't do that. There's been really good RCT evidence for years now showing that actually you get no increased benefit really beyond daily dosing, and actually probably alternate day dosing. I think the issue with alternate day dosing is that it can be more difficult to remember to take it. Which days have you taken? Did I take it yesterday or not? And but I think a lot of people just prefer having something that they take once a day. It really matters sort of counselling and explaining how to take it. So ideally in a morning, but actually morning and an empty stomach is sometimes difficult when you're pregnant. So people often will have like particularly if they've got nausea or vomiting or persistent hyperemesis, then sort of getting up in the morning, having an empty stomach, taking tablets on an empty stomach, and then waiting for your breakfast is quite difficult. So I'm not rigid about morning. I think it's about trying to find, you know, what pattern of eating is suiting that woman in front of you, and then finding a window of time when they are either before food, but it needs to be at least sort of an hour before food, or mid-morning or mid-afternoon. Vitamin C, we often tell women to have a glass of orange juice. Again, drinking orange juice when you're pregnant sometimes is quite acidic. It's not very nice. Sugar-free squashes also have vitamin C and are just as good, and actually that sometimes makes all the difference. And squash is cheap. Orange juice is actually relatively expensive, but having a bottle of Asda orange squash or Aldi orange squash sugar-free is easy, and it works just as well. Or Ribena or other brands are available, works just as well as fruit juice. And for some women, grapefruit juice, orange juice is just not a nice thing to drink when you're pregnant. Who do you need to be cautious with? Women with inflammatory bowel disease. So you can use oral iron, particularly women with active Crohn's or ulcerative colitis, but you do need to be really careful with it. And if a woman's had iron in the past and knows that makes her IBD flare up, don't bother, because it will do the same thing again. Some women will tolerate liquid iron or citron a little bit better. We've got a really good working relationship with the IBD nurses, and they will often sort of help in terms of replying to an email and saying, oh, this is what we'd recommend. Women that have iron-loaded state, so women with hemochromatosis, women who've had very frequent transfusions in the past, say if they've had a number of occlusive crisis with sickle cell, then you'd need to be careful. And they're often quite complex in terms of unpicking what are their blood results telling us. Do we need to treat? Do we not need to treat? And I would almost always get advice from a hematologist and kind of join up and make a plan. Most of our standard iron prescriptions we'll prescribe have roughly the same amount in them, but there's a little bit of variation, so you do just need to check, and it will depend what your local formulary has. GI side effects are really common, and that can be constipation, but it can also be an upset tummy, diarrhea, and just nausea and epigastric discomfort. Taking it carefully helps, but actually you can also switch to alternate day, and we've already said that works just as well. In fact, you get better absorption with low dose and spaced dosing of iron. BHS, and I think sensibly say slow release and enteric forms should be avoided. And the reason for that is you absorb iron very close downstream from the stomach. So actually, if it's not being absorbed and it's traveling all the way past there, of course you're going to get less symptoms, but you're not going to get very good absorption. So they don't work as well. So that as a tool to cope with GI upset isn't sensible. What you can offer if women really aren't tolerating and you've sort of tweak dosing and at the right time, you can use parenteral iron. So there's a good meta-analysis back in 2019 which showed that compared to oral iron, women achieved target hemoglobin more often, had an increased HB after 4 weeks, fewer side effects, but it is more costly. And it also has side effects. So we tend to use it for confirmed iron deficiency anemia. So you do need to make that diagnosis first. It's if you're prescribing parenteral iron, it has some risks with it. And I don't think we can be doing it without robustly knowing that this is actually iron deficiency anemia that we're treating. So I think if they've not responded to oral iron, you do need to go on and check other hematinics, look for the folate and B12 result before you can just default move to parenteral iron. If women are in very late pregnancy and they're anemic, then parenteral iron is a good option. I think because it's very easy, we did have a little patch where actually we seem to be getting referrals through for parenteral iron in women who had very low iron stores, but weren't actually anemic. And I wouldn't use it for that. The balance of risks and benefits, and we'll come on to some of the side effects, just isn't worthwhile. Contraindications, again, women with a history of iron overload or hemochromatosis, you wouldn't want to give them a big dose of parenteral iron. If they've got a history of anaphylaxis or serious reactions, and women who have autoimmune disease or who have a history of anaphylaxis to other infusions are at increased risk of reacting to parenteral iron. It doesn't mean you can't use it, but you may well need to be much more careful about how you're thinking about how you prescribe it and that counselling beforehand. None of the preparations are licensed or suitable at present in the first trimester of pregnancy because we don't have safety data for it, and active, acute or chronic bacteremia. So if somebody's septic or unwell, that again is a contraindication, and decompensated liver disease. But that would be relatively unusual. So genuine hypersensitivity is really rare. You can see the little table with the sort of rates. Modern parenteral iron preparations, regardless of which one your unit is using, across the board, they have very, very low risks of anaphylaxis, but they should be given in a setting where you've got treatment for anaphylaxis available, staff are trained, and it needs to be given in a setting. We do ours downstairs in our day assessment unit. I imagine that's what most places probably do. There are really rare case reports of fetal bradycardias with hypersensitivity. So I think if you're running a parental service, it does need to be in a setting where actually you can respond to that if that really rare thing happens. And the European Medicines Agency and BHS both say that benefits outweigh those small risks. And we've already talked about all the, downsides of having significant iron deficiency anemia. There's no doubt that properly treating this is a good thing, and parenteral iron is really important. I do think we all have to be very, very aware of extravasation. So this is a thing that can happen in up to 10% of infusions. Mainly can be mitigated by really careful siting of your IV access, careful checking, constant vigilance throughout the infusion. But the number of medical legal claims because of this are going up. So consider written consent, definitely provide written patient information, counsel and document, make sure your prescription is indicated so that women do fall into those kind of evidence-based criteria we've talked about. And just make sure that wherever you work, if you're prescribing parenteral iron, there's a sensible trust policy that supports that, and that sort of governance arrangement is around you. This is just our local guideline. We have had several cases of extravasation over the last sort of 3 to 4 years, and I'm aware that services around the country have as well. So you need to use a reasonable size cannula. Don't ideally put it in at your wrist or your elbow, and flush the cannula. If there is redness, pain, then stop the infusion, pull back, take out whatever drug is there, and flush through at the end. And that's just, a little graph showing that actually a reasonable number of extravasation claims through NHS resolution were due to iron infusions, and most of those were in a maternity setting. So I think it is something for us all to be mindful of. Okay, moving on to folate deficiency, and I've definitely seen more of this. So just some background information, dietary sources are broccoli, peas, chickpeas, brown rice, so green leafy veg. You have about a 5 to 10-fold higher requirement in folate during pregnancy, and we generally use a cutoff of less than 2 as being definitely deficient, between 2 and 4 as being sort of borderline. And women that are at risk or potential causes of folate deficiency, obesity, so often it's that malnourished obesity that actually there's dietary issues there. Women with bariatric surgery, particularly gastric bypass procedures, so Roux-en-Y and gastric resection, not so much the sort of balloon laparoscopic procedures that sort of make the stomach smaller. Women with very restricted diets we've already talked about, and alcohol abuse, which does happen. Signs and symptoms, you will get similar patterns in terms of anemia symptoms, but we all know there's a huge link between folate deficiency and neural tube defects, and really to address that you need to start your folate preconceptionally by about 3 months. There is an association between preterm birth and low birth weight, but it's not absolutely kind of like demonstrated through all the literature. And it's important to know that some countries around the world have routine fortification of basic foods, things like flour and cereals. We don't have that in the UK. So replacements or treatments, all pregnant women.
Yep, try that, Karen.
Yeah, is that working better?
Yep, I can hear you and I can see you.
Hurrah, apologies for
Great.
that. So, right, I'm going to try and share and go back to the slide I was at. Apologies, that is our third power cut this morning. Welcome to the NHS.
Yep. Yep, I can see your slides.
Right, so I think we were down on, I was scrolling through, we were down on folate replacement, weren't we?
Yeah.
So from current slides. Okay, great. No, that's not, I'm just literally going to flick down because it does not seem to want to play ball with me going from start. Here we are. Right, hopefully that's where we were, and I will try and get through the rest without further glitch so that you can have your lunch. So we know that all women in pregnancy should have 3 months worth of preconception folic acid, and then that should continue up to 12 weeks. So this isn't necessarily around folate deficient anemia, but just indications for the 5 milligram higher regime. So women that are known to be folate deficient, pre-existing diabetics, women with epilepsy on anti-seizure medicines which might interfere with folate metabolism, absolutely women that have had a previous affected pregnancy, and also women with bariatric surgery for those reasons we talked about. There are some controversies. So we talked a little bit about national fortification, and that's an ongoing live debate. The argument against it is, we'll come on to B12, but the theory that there are people out there with B12 deficiency, and if you give folate, then that may somehow cover that up and sort of cause neurological issues in them. There's definitely some controversy around duration of supplementation. Not so much if you are anemic, because then you need treating, but actually if you're using it for a kind of prevention basis, there's a little bit of emerging evidence around the link between high dose folate in women with epilepsy, not in women who don't have epilepsy, and the risk of childhood cancers. But there's actually a really thoughtful, sensible piece that UKTIS have written as a position statement, and I think the end of that, or the summation of that, is that actually we just carry on as we are for now and watch for any new evidence. So if anybody has picked up on that, actually it's a really sensible read. Risks and benefits. So is there actually any evidence that there's a benefit to continuing kind of high dose prevention folate for longer than the period that the neural tube takes to close? And then I've got a little bit on a slide about methylfolate and the MTHFR mutation, because, and I've put it's a side for me, I definitely have assorted conversations about this. But the bottom line is, actually, if you have got a woman and you've identified that she's anemic, perhaps she hasn't responded to iron, or she presented with a high MCV and you picked up on folate deficient anemia, then they need treating. So MTHFR is a really common variant. Varies a little bit with ethnicity. So women from Hispanic backgrounds are much more likely to have, but it can be up to 60% of the population. There is no indication for routine testing for this variation. Lots of women will come into your maternity service having testing for this, very often through fertility clinics. There's a huge amount of misinformation online, and often people will come worried that they have this mutation that's been identified, therefore they cannot metabolize synthetic folic acid, and they're concerned about it. There's a good myth buster from the CDC, and I've got the link at the end. There's also a really, really good little summary on Shine, which is a brilliant charity for spina bifida and hydrocephalus. And again, the link is there, but you can Google it. A really, really nice page addressing some of those concerns. So if you are having that consultation with somebody who knows they have this mutation and they're worried about it, explain yourself, but actually sometimes signposting to kind of, a sensible resource online can do a huge amount, and I often will open that up and look at it together with the women. There's no data at all that methylfolate, which is the kind of natural form or metabolized form rather than synthetic, is is any better. In fact, we just don't have any data for it at all. So given that we've got really, really astonishingly good data showing that folic acid for women that are increased risk and for all women reduces the chance of a neural tube defect, which is a really devastating outcome in a pregnancy, I would certainly feel very, very uncomfortable for just switching and using something in inverted commas that is natural, but there is no evidence base for at all. And I'd heftily recommend the CDC patient information, which is American, but also the SHINE page for being able to have sensible kind of discussions. B12 deficiency, again, I'm definitely seeing more of this, and often seeing it in the context of quite complex, like not just B12, because you will have women coming into pregnancy who know they've got pernicious anemia who are already being replaced, but actually women who have quite complex multiple nutrient deficiency or micronutrient deficiencies. And actually, if you've got somebody who's bariatric surgery, who's B12 deficient, then definitely go on and screen for your folate, your ferritin, and your micronutrient screen as well. And a lot of bariatric services now will offer, even for women that have gone abroad to have this. Certainly our local one has a really good dietitian, and you know, who's very, very helpful in sort of managing some of these more complex multi-nutrient deficiencies. And up to 10% of women, and again, it's that the group that is at higher risk are women that have had surgical resection of the stomach, so gastric resections, or women that have actual sort of more surgical gastric bypass operations. So unpicking what type of bariatric surgery somebody's had is important, and also how recently. Again, vegan and vegetarian diets, malabsorption, so women who've had small bowel resections, women who've got celiac disease or IBD, and again, prolonged use of proton pump inhibitors. The commonest cause of B12 is still pernicious anemia, which is an autoimmune condition where you don't make intrinsic factors, so you therefore can't absorb the B12, and that's more likely to go along with other autoimmune conditions, particularly vitiligo, and rarely, Addison's is a really rare condition, but they can go together as well. Signs and symptoms. So B12, folic acid, it's water soluble, you keep it in your body, you use your stores up by about 4 months, so things will declare themselves quite quickly. And we already talked about iron deficiency, and again, that seems to sort of declare itself over, you know, the course of months, maybe a year or so. B12 deficiency, you have an awful lot of stores in your body, and it can take 3 to 5 years before you deplete them down. So this can be quite insidious and can have been going on for a very long time. You can get neuropsychiatric manifestations, so cognition, memory loss. In its severe forms, you can get ataxia, pins and needles tingling, numbness, sensory symptoms. And you get symptoms of anemia, but it's really unusual to have that just in isolation. And again, you get glossitis, mouth ulceration, and you may, you know, where B12 deficiency is more severe, and that's really unusual in the context of a sort of younger women in pregnancy, but you might get neurological signs. Folic acid, and again, it comes back to that complexity, that mix of you can mask B12 deficiency, because if you treat with folic acid, then you correct, partly you sort of give enough of a boost to the bone marrow to be able to make new red blood cells, and there may be just enough B12 there to support red blood cell production, but you're absolutely run out of steam for any of your B12 stores for anything else, and you've not corrected that insidious kind of like years and years worth. So you may cover up the hematological manifestations, but leave the neurological side of things completely untreated. So I think it is about being aware that there's often common routes into more complex nutrient deficient anemia. So if you've got somebody who's iron deficient, who's not responding, then really think about, well, why? What else has gone on in their history? And actually, is it more than one thing, and how are they overlapping? And how do I make sure I treat both? In pregnancy, because it's nearly always a dietary or absorption problem, whether that's pernicious anemia or resection or bariatric surgery, you need to correct using a parenteral route, so IM. Sorry, I said it was dietary, or it's mainly absorption, not dietary. That's the commonest thing. There are regimes in the BNF. You can use the same ones outside of pregnancy as we do in pregnancy. And actually, if it's without neurological involvement, and this is the commoner type, then you have a regime where you treat with IM, hydroxycobalamin over 2 weeks, and then continue with IM injections after that. If there's neurological involvement, and to be honest, you would almost always have some hematology input or physician input here, then there's a much more intensive regime to replace and to track and wait wait until you've completely got on top of neurological symptoms and then space out to that maintenance dosing. There's some additional patient information resources. So there's a good section on the Tommy's website for anemia and pregnancy. Brilliant thing about the Tommy's website is you can go to the top right-hand bar and you can convert the whole website into whatever language you want. Your woman obviously needs to be able to read, and the difficult thing is you have got to do it with the women in front of you pointing, because the actual little language bar is written in their own language. So you can't go on and look for Urdu or Pashto because you've got no idea how that's written, the woman, and has to actually show you how to do it. But you can then translate the whole website for her, or she can do that herself if she's got digital access. So it's a really good thing. Iron deficiency anemia, the NHS is actually not bad. Some of their patient information is a bit tricky. There's a really brilliant video on the OAE, so they've obviously got skin in the game in terms of optimizing women pre-birth. And lastly, I think as a result of some of the global work to reduce iron deficiency anemia, but also hot topic because of our ongoing issues in terms of blood supplies, there's a good obstetric anemia toolkit available through NHS BT. So if any of those resources are of value to you, they're good. Guidelines I've referred to, the RCOG, British Haematology Society guideline from 2019, that's a really good one. And there's a little summary just generally in NICE. Further reading, there's a good podcast on blood transfusion. There's a nice American article about with some case report or sort of case studies of how I treat anemia, and particularly some of those complex ones where there's an overlap. There's a good TOG article on iron deficiency, and then I already referenced the CDC guidance. Thank you. I'll stop sharing if I can.
Wonderful. Thanks so much, Karin.
Hurrah. I'm sorry, you're probably all waiting for lunch.